Hello everyone, just want to introduce you to Dr. Janine Crifasi.
So these low-level lasers help the body to return to its normal physiological setting with that where it gets disturbed when somebody has something on the lines of oxidative stress or injuries or neurodegeneration or traumatic brain injuries. So what we do is we use these lasers to help the cells to heal. It helps the phospholipid bilayers. It helps the brain, which is called the mitochondria of each and every cell, to respond.
Okay.
The flashes of light that you see and the colors of the light all have meaning, and the neuroscientists and physicists that develop the programs, because there are a variety of different settings and frequencies that these can emit, helps to parallel what's happening. When patients reach this stage in care at the end of their sessions, we put them under the low-level lasers because what we're doing, albeit beneficial, can sometimes be stressful for the body. Even though it's in an effort to heal, the same way when we exercise, sometimes we get sore.
Yeah.
So this helps that healing process. For some patients, we'll put them on binaural beats. We'll also parallel that with some oxygen therapies. So again, this is just one of the treatment rooms that we have at the end of our treatment.
Okay.
Our diagnostics that we use, they vary. This room next to us,
Okay. And this for lost weight, this one right here.
that one's just for weight loss. Yeah,
Oh, weight
loss
loss,
or for
okay.
helping with breaking biofilms for patients that may have some level of compromise. This device here we use for testing, as we do here. We typically do bilateral blood pressures on patients when possible. It's always about safety first for patients. Do no harm. We do bilateral blood pressures because we expect certain things to happen on the right side and the left side, and we expect certain things when we go from seated to standing.
Oh, okay.
So for many patients, we'll test that. For patients that have compromised with changing the positions or unexplained fatigue and dizziness and sometimes orthostatic hypotension type things, we'll use this, and we wrap this heart rate variability monitor around them, and then it facilitates a report for us.
Okay.
So that we're able to see what is or isn't happening with their heart rate and their sympathetic and parasympathetic nervous systems under duress. And that will give us a digitized and a written printout to help us better understand, because the initial day is a fact-finding mission for us to be able to, to learn. This item is called a dynamometer, and it has, I don't know if you can see that, so I'm gonna turn it on first. It has digitized information in there that helps us to understand. We know in neuroscience there are certain things that can happen that when there's weaknesses that are reflective in grip strength, that can sometimes be an indication of premature neurodegeneration. So patients can help to protect themselves against that, and that's what the mission in our company is to help people not only recover but also protect themselves. So we have a balance tracking system, which timed out. That's John, demo guy. That's our practice guy. Get it? Demo guy.
Demo.
So let me go ahead. I have this set up a little bit wrong. I was going to ask that you don't show this part. Just
Oh yeah, no, I won't go close to it. It's more
demo
confidential.
guy, you can.
Yeah.
So this, pull up a whole report. We did several just to show people some of the things we do. We can do more on this. We can even do cognitive. We can do go, no go.
Okay.
So we have low risk and high risk that's associated with this, and medium risk. Every patient that comes through the door that gets tested, we want to know if they're a fall risk. Sometimes people don't know. The top person was a former employee of ours. Well, she's on medical leave with the family. But we knew she was always kind of clumsy, so it wasn't a surprise to everybody except for her that she was high risk. The second one shows, marked improvement from a high risk to a low risk.
Okay.
We don't always go that extreme, but when we can get people at least to a minimal risk, that's still progress for somebody that feels unstable.
Okay.
You can see it records digitally different things. We can do balance front to back and side to side, which all has clinical manifestations. And typically when these things happen, patients come in. This is just a practice. This isn't any particular patient. It's just to give data. So what this would show is, let's just say a patient comes in, they do stellar, and they never did their re-exam. We would expect their re-exam would be improved. But let's just say somebody has a new injury. That's what that would look like. And I can
Okay.
tell you that because truthfully, that's me.
Oh,
I was
okay.
doing fine, I just did it, and then I had banged my head. I'm like, wait, I need to go and look at this. So things happen, life happens with
Yeah.
patients. You can see it does give a digitized printout, which is great for objectifiable measures for patients and attorneys and things of the sort. And I apologize, I was on the phone with an attorney.
Oh, that's all right.
So when you first got
So
here.
I have a question.
Sure.
So I have a client that lost muscle mass because of health issues.
Of course.
And would you able to assist her when I refer her here?
All we can do is try.
So
You know, we've got to do the exam and
Okay.
see, and we'll talk about that in a little bit.
Okay.
You know, some of the other options that we offer. This here is, these are our more advanced cases that we do this with. This is a vestibular oculography goggle, a video nystography oculography goggle. And what it does is, this in here are cameras, and they're going to
Okay.
record eye movements, and I can show you this on a patient who shall remain nameless. What you can see, for example, I do have her permission, but I still like to keep it discreet.
Yeah.
We ask the patient to look straight ahead
Mm-hmm.
and to not do anything else. You can see that there's clearly a little bit of fatigue going on, because you see her eyes are sort of just popping back and forth. Make sure this
It
is
looked like the right one is fatigue. Is that right? Or the left?
Actually, it's more the left.
Left?
The left one is working a little bit harder, just knowing her case.
Oh, okay.
Then when we asked her to do some movements, like move her eyes up and down, and then look up to the left and down to the left, which we do all the time, and then to the right, you'll see she, first of all, doesn't even move her eyes all the way up when we ask her to. And then she moves them down, and it's very ratchety. It should be in a nice U or V-shaped movement, and we don't have that. Her processing on this was definitely not what we had hoped. She does have asymmetrical blink response at times, very sluggish to the response. You know, when we say move your eyes up, move your eyes down, that's what should be happening.
Okay.
And what happened with this particular patient is I'm going to show you what it's like. This is mimicking when we read, and we're pursuing across a page. Delay them. You see her eyes kind of catch up a little bit. They bounce back and forth. This patient actually was in a car accident where she was holding the phone for her husband. It fell. She took her seatbelt off as a passenger to grab it right when they got hit.
Oh, wow.
She got launched over the steering wheel. Thank God she didn't make contact with the steering wheel, and her head hit the windshield. She
Oh,
showed
wow.
pictures. Her hair was still on the other side of it.
Oh, my goodness.
So her biggest complaint when she came in was she was stuttering and stammering when she spoke. Yeah, she was kind of sore, but she was more worried she was going to lose her speech patterns worse. In her case, it was 10 visits. She was doing much, much better. So let me show you that repeat up and down. Somewhat better. At least she has better response to it. We got a lot better movement than we did in the other one. And again, this was only about 10 visits.
Okay.
So, when we
So this what you said neural mean more like the brain, right?
these are the more advanced neurology cases
Okay.
that we will use this with. So let me show you some of the other equipment, actually. If you don't mind. I'm going to ask you just to pause the filming a second.
Yeah.
You know, to put those on with flashing lights to you and I presumably would be annoying, but for somebody that has a deficit in there, that enhancement is just another way to have a multimodal approach so that the brain can start to heal from different ways. Because what we're doing is making sure the brain works independently and interdependently. Because when that happens, then the rest of our body can function better. Because I know you know this, you talked about that yourself in your talk, that the brain and the gut are integrally related, and if they're not taking care of each other, we're going to have some form of dis-ease in the body. And if left long enough, it may become a disease process or a degenerative process, and that's what we're trying to prevent here.
Okay.
We do a lot of work with the vagus nerve. I know you know Sarah, and Sarah does work with the vagus nerve in a different way, but that's because it's so important. That's why so many people are going and specializing in the vagus nerve. So these are a couple of the modalities. For patients that do have some vestibular issues, we help give them accoutrements. So you'll see these, when you put them on, they've got a laser.
Oh, yeah.
And they can track things with the laser. And, we do that, to enhance deficits and to dampen overfiring as best we can. We have, this is a sensory integration device where we have a lot of different activities that we can use. So, for example, this is really good for frontal parietal somatosensory cerebellar integration. What you can see is when you have this rhythm down, if you hit it hard enough, you see the green. If I'm a little late or early, okay, I can't even do it wrong. So that's late, that's early. We have to get that rhythm and timing down. That's really important for what we call long-term brain potentiation.
Okay.
We want our brains to be able to go and do things without always having to be brought back down again, or to have a trauma. Like I think I talked about, if not, you'll hear me say it tomorrow. 30 to 40% of traumatic brain injuries still have symptoms after a month. A portion of those still have symptoms at a year. And these symptoms don't have to be grandiose. Sometimes they are. Sometimes they have difficulty reading emails. They do 2 or 3 emails and they gotta lay down. Or they can't watch a show, or they find that they withdraw from social settings because of sound or light stimulation being too excessive. So some of the other therapies we can offer is we can have, patients have to identify what a letter and a number is, or we have them do something where they only do certain things, like only touch numbers with your left hand, and they're in a competition with themselves, which is good. So that's a motivating factor for patients. But we have to be very careful that we don't put them beyond. Sometimes we'll say, tell me something you would buy at the grocery store that starts with the first letter. So we have eggs and vanilla and octopus and Q-tips. But sometimes for some patients, like, you would think I was asking them about 3rd grade math, as a 2nd grader. It's just that they'll look at me and I'll say, give me any word from a book. And you would think that would be easier, but that's actually harder for people because you're giving them too much. We can do things like stimulate optokinetics. And I won't leave this on long because I don't know your story, but there's a whole lot of, like, this is, when you're sitting on a train or a car or something like that, we can do things where we can set it so that the optokinetics are horizontal, and we can do it with a target. Oh, I didn't do it with the target. I didn't do that right at all. Anyway, we can do it so it goes up and down and they follow a target. We can then move them forward and back using gaming chairs. We modify things a lot when they're in here. We can do auditory because sometimes people have processing, so we might say,
Write the following words in reverse sequence: funny, jump, big, help.
So if they're not paying attention or they first do it, it may be something where they go for the front order.
Find the
Good thing I didn't get that
following
wrong.
words.
This is a vibration plate which helps with somatosensory stuff. We can do lower extremities, upper extremities. We do have patients that are in wheelchairs that are quadriplegics, hemiplegics. We have patients that are amputees. I had a patient not too long ago, who broke his spine in a skiing accident. So these vibration plates are really huge. We start gross, with big movement type things. Sometimes we can put, these little bands around their arms and their legs to give them stimulation. We do mirror therapy, whatever it takes for patients. We can do things like this where there's activities that they can track. We'll have them on exercise balls or use bands or resistance or body blades, because we want to get them back to their maximum health as quickly as possible and as efficiently as possible.
Okay.
So come on this way.
Okay.
That other program that I was talking about, our brain restore program, offers a lot, and one of the main features that it offers is hyperbaric oxygen as part of the plan. So, and you see
Okay.
this chamber
Oh, I've been to this chamber before.
Yeah, so.
I love it.
Yeah, oh, it's great.
Yeah.
It's great, but a lot of the research has gone into this. We do things that are research. It's not something that he and I decide to do on a whim by any stretch of the
Yeah.
imagination. So we put together these programs for patients so that they can maximize their experience and get on with their lives, not have to come to us forever.
Mhm.
But to know that we're a resource, because statistically, unfortunately, statistically right now, by the year 2050, 1 out of 2 of us is expected to die with a dementia-related condition.
Mm.
Traumatic brain injuries are $56.3 billion a year. That's a lot of money. And that's mild, moderate, and severe, but still, that's a tremendous amount. And with people, having symptoms that much when there are options out there to take care of it. And, it's educating other doctors, it's educating the public. And so, for example, that's why I'm speaking this week at the Holistic Health Fair right here in Chandler. He and I, Dr. Berry and I, are known around the world, and patients come from around the country and around the world to see us, but half the people in Chandler don't even know we're here.
Oh.
So anyway, what questions do you have, Tweet?
So when this technology came about?
It varies. The lasers have been around for 40 years. The functional neurology has been around also around 42 years, I think.
Mhm.
Dr. Ted Carrick started. Dr. Daniel Amen and Dr. Carrick both started their research at the same time. Dr. Amen does his work, using scans and things like that and supplements. We do our work doing supplements and because of the brain-gut connection and the brain. But you can't just supplement your way, and you can't just exercise your way. People that do functional neurology without looking at the supporting networks of the gut and nutrition and things like that are doing their patients a disservice, in my opinion. So that's why we integrate so very much in this office. We know our lane, and we're happy to refer people out whenever it's appropriate to co-manage or to handle, or it's about patients, and that's what I wish more people would do, more practitioners, and I wish more patients understood that, because I want the world to be a healthier place. I got into it because I had relatives that were not getting adequate care in the offices that they were seeking care, and I knew there had to be more. And so as I started doing my own research, it linked itself to functional neurology. So
Mhm.
yeah. What other questions?
I know this for oxygen, right? To get more oxygen in your brain.
It's to get more oxygen to perfuse throughout the body.
Throughout the body. Okay.
So patients can wear either a cannula or a small mask and go into the chamber. And when they're in the chamber, for those people that don't understand, the chamber itself will fill all the way up, and it'll be solid. And when they're in there, it is safe. This type of chamber, people or a version of it can even have in their homes. It's safe enough. The big 2-person, 5-person one, the city wouldn't even allow us, but we didn't want to do that. We want to be able to help individual patients. So, these are very safe, and they will fill up with 95% concentrated oxygen, and the pressure that's built up around helps the blood to flow, where, again, many of our patients have been compromised, or, many of them are high-level athletes also, that are just looking to up their performance. But really, anybody who doesn't feel well is looking to up their performance. And if you still feel well, you're going to feel like you can do better, so you're still upping your performance. So I have to find some sort of a tagline associated with that, because that's really what it is. It's leveling up. So it's a really good complement to that. And then, when they're done, we put them on laser. Patients very rarely get out of here without going on laser. We do have laser. We have just the red lasers, or the lasers we can turn off. So if patients are sensitive to light, seizure patients oftentimes don't do as well with violet light. So we have that ability to accommodate, because it is about making sure that we're meeting the patient's goals, and the patient's needs. It's not what I want for them.
Mm-hmm.
It's what they want for them, and what they're willing to do for them. So, because it's not totally passive, we don't just stick an IV in somebody and say have a nice life, because we don't do that. But it's about a proactive approach to your health. and
Okay.
we'll do everything we can, for our patients.
Now, when you mentioned earlier the machine decompression,
Yeah.
that machine,
Yeah. Well,
um,
we can do that.
what does that do in that?
Let me make sure. Of course, it's the one machine that got turned off today. It'll just boot up. So this table can be adjusted in a variety of ways. We've had patients that have been nearly like this when we did. Of course, it has to be adjusted. The other part has to be adjusted differently. And what this does is this is set up for cervical traction right now,
Okay.
where I can put in values. For example, let's just say I put in 2917. I have the ability to do it at a static traction to allow that disc that's cooching out on somebody, possibly affecting a nerve root or the spinal cord, to just let gravity pull it back in.
Okay.
I can do it so it's intermittent when it's deemed appropriate, to allow it to start getting used as an active joint, not a splinted joint anymore. This would go over the forehead. It is set this way. And again, so I have the two different ways. Patient there's a panic switch that comes with it. Of course, we can hear them. And then we set them up and we leave them alone.
Okay. So basically, it even out the spine and the nervous system.
What it does is it takes the pressure off. It's usually used when there's a disc injury, or for myself, I have 2 spinal fusions in my low back. So I need to get stretched because the way I carry myself, and I can't move all my joints very freely. It's not often, but when it happens, I need it, and I like to get it out.
Okay.
So, but for these patients, it's a good conditioning to help get them, and to make sure those joints are stable. When somebody has an injury, whether it's a chronic injury that was unresolved, original injury, or it is a newer original injury, it has to be managed, because otherwise the body is going to compensate and break itself down. And we don't want that. So if we were to set this up, if I may, I'm going to sneak right past you. Quick. Variation on the theme anyway, just because it's set up the other way, but just to give you a general idea. And there's a lot of different types of therapies that can be done, but we can hook this way. Hook the other one this way, and the patient would basically get cinched in as such.
I see. Okay.
Like this.
Okay.
Then these. Oops. I must have got it caught in there. But this thin strap would come across here. This would be set like that, so they almost look like they're getting ready to jump out of an airplane. Of course, this wouldn't be here. And then these two would be connected. And
Okay.
it would be set up for lumbar. And then if you watch, then this table would also be loosened,
Okay.
and then they'd be pulled. Not that aggressively,
Yeah.
but just to give you an overview
Yeah.
of what we would be doing. So that traction, again, opens that up, relaxes muscle spasm, and it's very concentrated, it's very specific. In previous offices, I used to have tables that I could move manually. I could move that disc. This is an axial traction. This is all linear, and it's not manual. So it reduces the risk of injury to myself and to the patient, frankly.
Okay.
So I like controlled, modified, methodical things.
Okay.
Great.
All right. Thank you so
Thank you.
much. I
Thank
appreciate
you.
that.
Let's have a seat right out here, because I'll talk a
Okay.
little more about your practice.
This is the reception area. Get this here. Let's be a community, empower one another.